Good morning. Welcome to Malawi. My name is Zengani Chirwa. I work with the Ministry of Health in the Department of HIV and AIDS as a technical advisor. So today I'm going to attempt to give you a glimpse of the Malawi experience in terms of integrating ART and PMTCT services, as well as option B+. Now, on the background, Malawi is a landlocked country. It's found in sub-Saharan Africa. We have about 14.9 million people, according to our last DHS. Our prevalence in the Sentinel surveys done in pregnant women is about 11%. We estimate from Spectrum about 1 million people living with HIV in Malawi, and also approximately 1 million orphans. Our ART and PMTCT programs had been run separately previously as vertical programs, and that's one of the issues that we were trying to address going forward. We are a limited, resource-limited country with a single donor, that is Global Fund. I don't know up to now how we missed the PEPFAR boat, but somehow we missed it. Most of our neighbors have got both PEPFAR and Global Fund, and this actually has got quite an outstanding consequence on implementation of our programs. Now, after the WHO recommendations in 2010, we came up with our objectives for our implementation. And this included to increase access to triple ART for HIV-infected pregnant and lactating women, to reduce morbidity and mortality among HIV-infected women and hence their children, to reduce transmission of HIV from mother to child, to try and reach the target of virtual elimination, which is less than 5%, and also to reduce transmission between discordant couples by targeting pregnant women. And this is the so-called treatment for prevention. We also wanted to improve adherence in PMTCT by integrating our ART program into the PMTCT service, and also integrate family planning services into the ART and PMTCT services, giving dual protection as per prong 2 of PMTCT. So, what was the rationale for option B+? As a resource-limited country, we realized that we were going to have challenges with the WHO recommendations of option A and B. And I think the biggest challenge was the lack of CD4 capacity in most of our health facilities. I think we only have about 50 CD4 machines in the whole country. And for these were obviously not enough, because both option A and option B are highly CD4 dependent. Essentially, you cannot make a decision on whether somebody needs ART for their own health or not without doing the CD4 count. And this is a problem we realized we had in our PMTCT program, and most of our women were being put on either single-dose nevirapine or AZT combination therapy, and yet they probably needed ART for their own health. There are also other issues. We have a very high fertility rate in Malawi, and when we looked at option B, which meant you start and then you stop after breastfeeding, this led us to think that our program will not be able to cope with such an approach, because it would mean you'd have to do that 3-4 times in one woman in her reproductive health, which we thought was going to be a real big challenge, and we were not very sure about treatment interruption impact later in these women. Also, the study which was mentioned yesterday by Hargrove in Zimbabwe showed that there was high postpartum mortality in HIV-infected women, even at high CD4. So why not start early on these ladies? When the HPTN study results came out, this sort of was very, very good news for us, because we knew that our approach is a subset of treat and test and treat. So we had quite a nice debate on what we should call it, because it was neither option A or option B. We thought of option C. Then we thought, no, that would maybe gain us the wrath of WHO. So we said, okay, maybe modified option B, which still looked like a mouthful. So finally, we settled on option B+. We attended various fora where we tried to rationalize why we were trying to take this approach. And we even submitted an article which was published in the Lancet in 2011. I think if you'd like to get more details on the rationale we had, you could look that up in the Lancet. It's quite detailed. Right. So in guidelines, the full implementation involved providing universal ART for HIV-infected pregnant and lactating women, irrespective of WHO stage and CD4 count. Also, early initiation of ART at CD4 less than 350, phasing out of trimune in both adults and children, and providing standard pre-ART and exposed infant follow-up, and introducing routine viral load monitoring for all patients at 6 months and thereafter every 2 years. So we had another option, and this followed our application for round 10, which was unsuccessful for various reasons, one of them being that probably the budget was too large because of the new drug wanted to introduce for everybody, the tenofovir. So our budget, I think, reached something like 300 million in 5 years, and it was not successful. So we had to look at other options of how do we implement these guidelines. And in this case, we are looking at providing the TDF-based regimen for certain groups of people with proven benefits. For example, new HIV-infected pregnant and lactating women who are not on ART would receive this, new TB and HIV patients, and also current patients who have developed severe lipodystrophy. Meanwhile, the rest of the clients would continue to initiate on trimune. So we did some projections on the implications of scaling up integrated PMTCT ART with option B+. How does this work? Can it be seen anyway? I don't think so. Anyway, the black line there represents patients in need of ART at CD4 of 350. The red dotted lines are the actual patients alive and on treatment per quarter. And you see it's a perfect line, and you can actually extrapolate it, and it can give you can get projections of how many patients we're going to have alive and on treatment by 2015. Now you can see around 2010, that's where now we're introducing PMTCT option B, and you can see that there's a sharp rise. And in fact, by 2015, we will have begun surpassing the number of patients in need of ART. So this was very encouraging, and we were determined that we should take that path. So the problem of resources was a very, very big problem. We had lost out on round 10. Lucky enough, we had the RCC, the Rolling Continuation Channel, which was running for 6 years, and we were just about to complete 3 years. So we would go into the next 3 years. But of course, this budget was based on trimune, so it was not adequate to fully implement our new guidelines using tenofovir. So these were the sort of options that we had. Option 3, of course, went business as usual, continue with trimune, don't do any option B. And that one would have costed us $182, and it was going to be for 3 years. Now, when we look at the full implementation, which was option 1, we said, okay, we can shorten the period to 2 years, reprogram the funds in the RCC, and it was coming to 237, which was way above our 177 that we had available. So we had to pick on option 2, which was reprogramming and reducing the years to 2 years, and this was coming to 169, which was within our budget. Okay, this is what I've just mentioned already. Round 10 was not successful. Round 11 grant was withdrawn, and who knows about round 12. So essentially, we were stuck with option 2. So the interventions that we had were included merging the 2 technical working group committees who should plan the integration and the implementation of option B+, integrate ART into all the maternal, neonatal, and child health services using option B+, and also integrate provider-initiated family planning, PIFP, into ART services. And we know this is the prong 2 of PMTCT strategy. And initially, we would just be providing Depo-Provera and condoms with an option for referral for other methods. So there were a couple of milestones which were reached. One was policy development, which was approved. Then we developed the guidelines, integrated guidelines covering option B, pre-ART, early infant diagnosis, and exposed infant follow-up, together with treatment for adults and children. We developed training curriculum and manuals for the integrated services, including pre-ART and exposed infant follow-up. So before December, that was early 2011, we managed to train 120 trainers in integrated services. Then we trained 4,205 current healthcare providers in the integrated services. So what we did was that we had separate providers for ART and separate for PMTCT. We brought them together and trained all of them in integrated services. It was like a military operation, you can imagine. And I think we've managed to complete it in about 4 or 5 months. Now, so we started now providing ART in 654 ART PMTCT sites. Of course, we used to have only 300 ART static sites. So now we extended the service to include the PMTCT sites at the antenatal, maternity, postnatal, and we're also catching mothers in under 5 clinics as well. So by December, we had about 323,000 patients alive and on treatment, which is about 73% out of 443,000 ever registered on ART. Out of these, almost 4,000 pregnant and lactating women were initiated on the TDF-based regimen in the 3rd quarter, and 14,000 were initiated on tenofovir in quarter 4. So in quarter 3 is less because we had just started, and we even started late. I think ARVs arrived in sites somewhere in August last year. So this is a graphic picture of our scale-up program since 2004. You can see that there's been great acceleration. In the last 2 quarters, quarter 3 and quarter 4, it's not very evident there, but I think it will become evident in this slide, showing that total ART registrations have tremendously increased. In fact, they've almost doubled. Our average used to be about 18,000, and you can see in quarter 4 we have 34,000. So this is unprecedented, actually, to have almost doubled the amount of initiations we have. And most of this is due to pregnant and lactating women, although we also have a lot of patients now coming in because of the CD4 below 350. Now, this is an interesting slide which I just wanted to share. It's essentially showing the relationship between late initiation of ART and mortality. So we can see that consistently from 2006, as we start less and less patients in stage 4, the death, the early mortality is also decreasing simultaneously. And we can see that in 2011 quarter 4, the mortality has almost reached about 3%, and the patients who are starting on stage 4 has decreased to about 6%. So there seems to be a very good correlation between early initiation and mortality. Now, we also embarked on a clinical mentoring program because we knew that these are providers who have just been trained and they need support out there. So we trained 359 clinical mentors, and the mentoring has begun in most districts. This is to ensure smooth implementation. We have a very robust M&E system, if I may say so myself. We conduct quarterly supervision. This is integrated to all the sites providing ART and PMTCT. And in these supervision visits, we do cohort analysis, we collect data, we do mentoring as well. We have 4 patient master cards that we have developed. Right. So the blue one is for pediatric formulations. This one is supposed to be yellow. I don't know what has happened to the color, but it's the adult formulation card. And then the pink one is for exposed infants, and the green one is for pre-ART for both adults and children. Now, of course, there are challenges, and the most obvious one is the human resources. Only about 20% of our sites fulfill the minimum staffing norm, despite the task shifting. So, essentially, any clinician, nurse, doctor, clinical officer can initiate ART. So this can happen at the health facility level in remote areas where they are able to give ARV. Of course, we've got infrastructure problems. Storage space for drugs and test kits is an issue. Supply chain management, because now we are dealing with 640-something sites from 300. So this also poses challenges in terms of quantifying, distributing HIV commodities. Adherence is also an issue. We know that we are now treating people who are absolutely healthy, and so adherence issues will always come up. What we are doing to try and mitigate that is that we are giving them the full counseling on adherence that we normally give for ART. And secondly, as I mentioned earlier, we're introducing routine viral load monitoring so that we can detect any treatment failure early. Funding, as I said, is a big issue, and we are not sure what the future is going to hold for us. We are hoping there will be around 12 sometime later, which we will apply and hope that it will be successful. But of course, we are appealing to any donors who can come to our rescue. We are very much welcome. So what are the key considerations? Integration of ART and PMTCT services has simplified and streamlined our PSM system. So you train everybody in ART and PMTCT. You can do forecasting for both 2 programs, which have become one. Quantification, procurement has become simpler, and even the M&E has now become simpler. So the health systems tend to get strengthened by removing the differences between PMTCT and ART providers and increasing their flexibility to treat patients, whether it's a PMTCT patient or it's an ART patient. And the integration of ART and PMTCT at all levels has also simplified the implementation of option B+, because this was one of the big headaches we had initially. So how do we give ART to PMTCT patients? So the answer was, let's just integrate them and treat it as one program. Right, so thank you for listening. I'd like to acknowledge the staff of the HIV/AIDS department who have done a tremendous job to try and make this successful. Special mention of Dr. Frank Chimbwandira, Dr. Andreas Jan, Dr. Eric Shoten, and Dr. Moses Batenganya, as well as thanks to ITEC Malawi for making it possible for me to come here. Thank you very much.